this is our Vertigo Talks episode 12, and I'm really grateful to Dr. Sriharsha for giving me this opportunity. So let us start our episode 12. So coming to disclosures, like I have nothing to disclose, informed consent obtained from the patients, and I'm sharing my personal experience. And there are places where I don't have data to back up my findings. And so basically today I'm going to present three cases of infantile nystagmus, and the summary of my findings of patients with motorist vestibular disorientation syndrome. In the last presentation I told about motorist vestibular disorientation. I presented 7 or 8 cases, and we have now around 18 cases along with Kochi Medical Trust Hospital, where Dr. Preeti, she has 3 cases, and I have 15 cases. So together we have around 18 cases, and I'm going to present the findings. So coming to the nystagmus, if we look at the nystagmus, their localization for the nystagmus either lies into the peripheral vestibular apparatus, that is semicircular canals and the vestibular nerve, and functionally the that vestibular nucleus. So either the localization lies into the peripheral vestibular apparatus or the brainstem or in the cerebellum, or sometimes less commonly it can happen because of anterior visual pathway defects and cerebral hemispheric lesions, which usually manifests at birth, and it presents as a developmental disorder, and the nystagmus can start appearing after 8 to 12 weeks of birth, and which is called as infantile variety of nystagmus. So basically, the earlier terminology for this nystagmus was congenital, but many a times it is not seen at birth and it appears later in life, usually in the infancy. That's why it is called as the newer terminology is infantile nystagmus syndrome. Now, if we look at the prerequisites for a stable vision, we need a stable vision many a times during our activities. So how this stable vision is maintained? There are three mechanisms. One is the gaze. The eyes, the gaze should be maintained on the target. So the eyes should maintain wherever it moves to one side in the any of the gazes, it should be stabilized according to the head movement. That is first. The first is whenever the head moves, the eyes should make compensatory adjustment, that is gaze stabilization despite the head movement. Then the second is, I was telling first, was the gaze holding mechanism. We should be able to hold the gaze in eccentric positions of the eyes, that we need neural integrator for that. And for this we need the vestibulo-ocular reflex and the optokinetic reflex. And the third mechanism is visual fixation and inhibition of unwanted saccades, that we need anterior visual pathways for that. So let us see which are the structures which are needed for these prerequisites for stable vision. So we need vestibulo-ocular reflex for gaze stabilization despite the head movement. The eye movements compensate for the head movement. Now, gaze holding mechanism is neural integrator, and a neural integrator helps to maintain the steady gaze at eccentric position. And the visual system we need to inhibit the unwanted saccades and to focus on the particular target. Even if there are certain things happening in the peripheral visual field, then we need to fixate on the fovea and foveal vision. In many a times we need that attention. So that's how we need to inhibit the unwanted saccades. So coming to the pathophysiology of nystagmus, if there is any defect in vestibulo-ocular reflex, it manifests with the peripheral vestibular variety of nystagmus, in which there is a slow phase and there is a fast phase, and the slow phase has a linear velocity, slow phase velocity. So basically, the slow phase velocity could be of three types. It could be either linear velocity, linear, like it is the slow phase velocity is remaining constant throughout, and there is a fast phase. So this is a left beating nystagmus. The right beating nystagmus will appear in this way. Okay, this linear slow phase velocity, and so there is no increase or decrease in the slow phase velocity throughout from one point to the another point. So it's very important to differentiate the pathophysiology of nystagmus. The slow phase velocity or the curve of the slow phase velocity will help in deciding the pathology. That's what I'm going to demonstrate in this lecture, like how the video nystagmography can help us to differentiate the pathology. So this is about this linear velocity slow phase. Then comes the, if there is a leaky neural integrator, if there is a lesion in the brainstem or cerebellum affecting the neural integrator, there could be a decreasing slow velocity curve. So if you look at the velocity here, okay, if from here to here and here to here, so what happens is the this is moving faster as compared to the this particular thing. So what happens is the velocity is reducing as the like the eyes are moving. So this is a decreasing velocity slow phase. And the third variety is increasing velocity slow phase. So if there is any defect in the visual pathways or like cerebral centers for ocular pursuit, retina, or faulty neural integrator, cerebellum, it can lead to the this type of variety of nystagmus, in which the velocity is the slow phase velocity is increasing. It increases over a period of time. Now let us see the various pathophysiologies of nystagmus. The first one I told, if there is any problem in the gaze holding mechanisms, if the gaze holding mechanisms there is any issue, either in the issue in the vestibulo-ocular reflex, neural integrator, or visual pathway defect, it can lead to nystagmus. Or there are certain developmental disorder, but the developmental disorder can affect the visual pathways and can lead to this infantile nystagmus syndrome, which is earlier known as congenital nystagmus. Or there is another type of nystagmus syndrome called as fusional maldevelopment nystagmus syndrome or latent nystagmus syndrome. And there are certain varieties of nystagmus where the pathology is not well understood. These are the varieties of nystagmus where the exact localization or exact pathophysiology is not known. Now, as we know that nystagmus has fast phase and slow phase, and the most common variety of nystagmus is a jerk nystagmus, where there is a fast phase and there is a slow phase. So here we are seeing the slow phase, and this is the fast phase. And the nystagmus is named after the fast phase. For example, this nystagmus is beating towards the left, so it is a left beating nystagmus. It is beating towards the left side. But the pathophysiologically, the slow phase is the very important. The slow phase velocity, whether it is exponentially increasing, decreasing, or a linear slow phase velocity, that will help us to decide whether what type of lesion the patient has, what type of pathophysiology patient has. Now, if there are two slow phases in the nystagmus, it is called as pendular variety of nystagmus, where both the phases are of equal amplitude and of equal velocity. So then it is called as pendular variety of nystagmus. And the nystagmus like movements are nothing but, there are variety of nystagmus like movement, like microsaccadic oscillations, the square wave jerks, and the ocular flutter, ocular okay. So these are the various types of nystagmus like movements which can happen. And in these kind of movements, there are both are fast phases, and there is intersaccadic interval. There is these are actually saccades which are having some intersaccadic interval. You can see it is a saccade, and there is a intersaccadic interval in between. And so now coming to the types of slow waves, as we were discussing, the slow wave could be of linear velocity, or this is left beating nystagmus, as I told. If it is a right beating nystagmus, it will appear like this. Okay. Now this is about linear velocity, which is seen in defect of the vestibulo-ocular pathway. Now here you see we will actually see how much distance is covered in this much time and this much time. So here it is covering this distance covered is if you see, like, from here the eyes are reaching to here. It is taking little longer time as compared to this is moving faster. Okay, so that's why the velocity here, there is exponentially increasing, sorry, this is exponentially decreasing slow velocity, because this velocity is slower as compared to the this velocity, because if we compare the degrees, this is the degree of eye movement, so this one is the degree of eye movement. So the eyes are moving this much, only this much movement is happening around in the same time. So I will tell you again. So suppose this is a point A, okay, and this is point B, and this is point C. Okay, so the eyes are moving from here to here and to here. Okay, and this is the duration taken by the eyes, to move from this point to this point. So almost the equal time is taken, but the distance covered is faster here as compared to here. Okay, so that's why the velocity here is faster in this phase as compared to this phase. So this one is slower, the second one. So it is exponentially decreasing slow phase velocity. So exponentially decreasing slow phase velocity. But again, this is a right beating nystagmus. This is going beating towards the right side. If we look at a nystagmus which is beating towards the left side, so for example, if a nystagmus, this is beating to the right. So if it is beating to the left, and we have to plot exponentially reducing slow phase velocity, then we need to plot like not like this. I will tell you this. So exponentially decreasing will be like this. Okay, here the distance covered will be more as compared to the distance covered here. So this is what is important, because this is little confusing. So that's why you have to actually calculate the degree of movement happening here. Okay, so the degree of eye movement happening here is more in the initial phase as compared to the second phase. That's why it is a decreasing velocity slow waveform. And here now you see, from here it moves here, and then it moves faster here. Okay, so it is taking less amount of time in this phase as compared to this phase. That's why this is increasing velocity slow waveform. So this is increasing velocity waveform, and this is pendular variety of jerk, like pendular variety of nystagmus, where both the phases are of equal duration and of equal amplitude. So the nystagmus present since infancy without any you. What are the clues now to congenital nystagmus or infantile nystagmus syndrome? So it is very important to take a proper history whenever you see. I'm an adult neurologist. So for example, an adult patient comes with some other neurological symptom, and patient is obviously having the eye movement. So it is very common to see this. So it's very important to ask the patient whether the patient has noticed eye movements, or the relatives have noticed these eye movements are present from the childhood, or they have appeared recently. That's a very important clue for the diagnosis of this infantile nystagmus syndrome. Otherwise, many a times these patients undergo admissions, unnecessary testing. Then and many times they don't have neurological symptoms also, and they come for something else, and if the nystagmus is seen, and they can undergo neurological evaluation in the form of MRI or urgent admission. Occasionally, patients are not aware of this presence. That's why it's very important to clinically differentiate between this infantile nystagmus syndrome versus the acquired variety of nystagmus. And when they present with other neurological symptoms, it can create a panic reaction, the physician, and it can lead to these issues. And differentiating it clinically is very important. So this is something, this congenital nystagmus or infantile nystagmus syndrome is something similar to early repolarization changes in the ECG. So there are different varieties of early repolarization changes and which are physiological. But it creates a lot of when these patients consult for some other reason an ECG is taken, they are subjected to TROP-T, angiography, admissions, repeated ECG monitoring, despite not having the chest pain. So it can happen that because the ST segment looks elevated, these patients undergo evaluations, repeated evaluations. So it's very important to know the normal variants and to compare with the previous ECG in case of early repolarization. Similarly, in case of congenital nystagmus, it's very important. We should compare with the earlier stage, and we should ask the patient whether they had a similar history in the they had these eye movements in the past from the beginning. Now, coming to the various varieties of nystagmus which are seen in childhood, the most common being the infantile or infantile nystagmus of idiopathic in nature. Many a times we these patients are not having any associated ocular disease or any neurological disease or neurological symptoms. So many a times these infantile variety of nystagmus is idiopathic. They don't have any other neurologic or ocular abnormalities, and they come with isolated eye movement abnormality, isolated nystagmus most of the times. In the adulthood, they will come with, but in the childhood, it's very important that the pediatric neurologist or pediatric neuro-ophthalmologist or the pediatricians, they or the ophthalmologist, they evaluate the patient for various neurological diseases, neurological syndromes, ocular diseases, because they can have associated variety of these disorders. But in adulthood, if a normal patient having no other ocular and neurologic abnormalities, patients can present with congenital variety of nystagmus. It's very important to check whether they have albinism, because there are certain syndromes associated with that. Ocular diseases, neurological diseases. Spasmus nutans is another variety of nystagmus seen in childhood, and another variety called as manifest latent nystagmus syndrome. So this is primarily related to the pediatric neurology. These are the varieties of nystagmus which are seen in childhood, and these patients we can see in the adulthood, and they can create diagnostic dilemma if they present with some other neurological disorder. So infantile nystagmus syndrome, the prevalence is 1.4 per thousand. They can have associated sensory defect, anterior visual pathway defect. The infantile nystagmus syndrome, the age of appearance is very important. Usually, it starts early in the life, and that is between 8 to 12 weeks or later, rather than being present at birth. That's why it is named as infantile variety of nystagmus by the recent nomenclature. Like even in the Barani Society has mentioned to emphasize this term infantile nystagmus syndrome than the congenital nystagmus. And knowing when the nystagmus first appeared is very important to know the underlying cause. And there are variety of symptoms like patients can have. They can just have wiggly eyes without any symptoms, or the patients can have a distant stare. They might be looking through you, like they might be looking at a distance, and they can have head oscillations along with the nystagmus. They can have head tilt because of the null point. They can have refractive errors like high myopia, heteropia, lazy eye, other eye diseases, and 30% of the times they have associated strabismus. So to make it simple, to make it simple and to understand it better, there is a mnemonic like called congenital, like the name, the previous name indicates, where we will go one by one the characteristics of this variety of nystagmus. The C stands for convergence. So let us go one by one into the characteristics of this nystagmus. Now, the patients with infantile nystagmus syndrome often have good vision unless associated with the afferent defects, and convergence of may suppress or reverse the direction of nystagmus. So, I will show you one of my case. In last week, I have seen one patient where now I hope you can appreciate this patient had right beating nystagmus initially. Okay, more of a pendular or right beating in nature. And when I asked to converge, the patient developed left beating nystagmus with little downbeating component on convergence. And again, on removing the convergence, the patient has again this right beating component. So again in convergence, you can see the patient developed. So the nystagmus direction changes in cases of congenital or infantile nystagmus syndrome. The nystagmus direction changes or gets suppressed. Usually it gets suppressed, but it can reverse the direction. That is important finding. It will help to differentiate it from the acquired variety. This is the graph of the same patient. I'll show you. For example, if you can look here, the patient is having right beating nystagmus. So the actually it is not a linear slow phase velocity. It is exponentially increasing slow phase velocity. You can see here individual waveform if you can see. And in till this phase, I didn't ask the patient to converge. After asking the patient to converge, you can see from here to here, the patient has developed this jerky variety of nystagmus, which is beating to the left side. So left beating nystagmus the patient developed. Initially, it was more of a pendular variety or a jerky component towards the right side. And then again, after removing the convergence, the patient again went back to the right beating variety. So this is the effect of convergence, which is very important in this variety of nystagmus. Then coming to the second feature, that is oscillopsia, like what happens in these patients. So patients with this variety do not experience oscillopsia, the illusory oscillation of the environment, due to compensation, because compensation happen from the childhood. The compensation happens because of this defect, and that's why they don't develop oscillopsia, although they have very much visible nystagmus. That is another clue in the diagnosis, because it's very important clue that if a patient has very like gross oscillations of the eyes and in the adulthood and without any symptoms, then it goes in favor of infantile nystagmus syndrome. And these patients get decompensated, like unless in later life, if they develop any head injury, decompensated strabismus, retinal degeneration, or some any other neurological disorder they develop, it can get decompensated, and the patient can experience oscillopsia. That if they, that is another thing which can happen in these patients. Now coming to the next thing is like null point. What is this null point? Let us see. So a null zone is wherein the nystagmus intensity is minimal may be found. So for example, the eyes are in center, straight ahead gaze, right gaze or left gaze. Okay, there is a point where the nystagmus is minimal, either on the right side or left side, or it could be in the center. So usually it is found on the one side, and that leads to the head tilt, compensatory tilt of the head. And if this zone is on one side, the affected person turns the head to improve the vision, because the nystagmus is minimal in that particular null point, and that's how the foveal vision the patient can achieve. and that's why the some patients develop head tilt, and that is what is used in patients for the surgical treatment of this infantile variety of nystagmus. In this surgical treatment, there is a resection of these lateral recti or medial recti or other muscles, and that can help in reducing the nystagmus and creating that null zone in the straight ahead gaze, and that can help the patient in improving the vision. Those patients who have oscillopsia or have visual symptoms, it can help. Now, coming to the next thing is gaze, like gaze, uniplanar gaze. That is, for example, I'll show you. Okay. So look at this patient. She has, at baseline, there is a squint. If you could appreciate, if she is looking to the left, there is left-sided gaze evoked nystagmus. On right side, she had right beating nystagmus. On up gaze, the nystagmus remains horizontal, pendular, in a pendular fashion. And on the down gaze, also it remains horizontal. That's the peculiarity of this nystagmus. It remains horizontal even in vertical gazes, upward and downward gazes. That's a very important finding, which helps to differentiate between this variety of nystagmus and other acquired varieties of nystagmus. And at straight ahead gaze, if you can see again to the patient, this is in the center, and you can appreciate that little squint in the eyes, like that strabismus is there. And this patient had a null zone. This patient felt better while reading. She converges her eyes while reading, because convergence helps to reduce the dampen the intensity of nystagmus. So convergence helps in reading, focusing on targets. Then another thing is to keeping the target in the null zone also helps them to focus. So this is one patient. I'll go to the. Now, there is a reason why the trajectory of infantile nystagmus remains in horizontal in vertical gaze. I'm not going to discuss today. Like, it's a 13-minute video which I have done, because these equipments I searched, I couldn't find, and I have done one YouTube video long ago, like 1 year ago, where I have described why the nystagmus of infantile variety remains horizontal in vertical gaze, because it is respecting the eye reference frame. It is not respecting the head reference frame. So it's very important to remember that the central varieties of nystagmus, the congenital nystagmus also, they respect the eye reference frame. And the vestibular variety of nystagmus is locked to the head reference frame. That's why when the nystagmus of BPPV is torsional on one side and upbeating on the other side, and in the center it is upbeating torsional. So in patients with posterior canal BPPV, just do this thing. When you are doing the Dix-Hallpike, ask the patient to look one side. If it is a right posterior canal BPPV, ask the patient to look to the right. It will be predominantly torsional. If you ask them to look to the left side in the right Dix-Hallpike position, you will find they will have predominantly a beating component, and in the center gaze they will have a beating torsional. And better to look this with some method for removing fixation, that is either the video frenzel or this VNG system, or in the dark we using this system. So it's very important to remove fixation to appreciate the separation of the nystagmus in patients with BPPV. This is the link for this video. For example, you can go on my YouTube channel. NeuroPPTX is the name of my YouTube channel, and there you can see this particular explanation of around 13 to 15 minutes why it remains horizontal. Now coming to the this we have discussed this gaze uniplanar. Now we will discuss the equal in amplitude. So we are going through this mnemonic congenital. We have come up to the E, and it is equal in amplitude. So for example, if you see on this graph of the VNG system, you can see this is equal in amplitude on both the sides. Okay, so it is a pendular variety of nystagmus. Okay, and here also you can appreciate this pendular variety of nystagmus. So mild jerky component will be there many a times, but it is a pendular variety of nystagmus. Here you can appreciate. Here you can appreciate a little better, like the pendular variety of nystagmus. So then comes there are some nystagmus characteristics which we have already discussed, but I will just like mention them. That is, these are the conjugate eye movements. Usually it is horizontal, but sometimes it can be upbeating or downbeating variety of congenital nystagmus, very rarely. And there is usually increasing velocity jerk, like as I have mentioned. For example, uh, this variety of nystagmus, like I will show the graph in this particular patient. I think I have shown, like initially the velocity is less initial part, and later the eye is covering the more degrees, and here it is lesser distance is covered by the eyeball. So this lesser distance is covered in the same time, but in the later phase it is covering more distance, that is more velocity. So typically there is increasing velocity jerk and pendular waveforms, and there are brief foveation periods in between where the patient tries to fixate on the targets. So subconsciously they keep fixating in between the two jerks or in between the two pendular waveforms. And these nystagmus, it increases on lateral gaze, we have seen. It becomes jerky on the lateral gazes, and there is a null zone, and there is a head turn, depending on which side is the null zone. And less common patterns of this nystagmus are periodic alternating, upbeat, downbeat, or seesaw nystagmus. And rarely there could be nystagmus in vertical plane, circular, or cycloid pattern. So it's very important in these patients to go through the history, since what age it started, what are the associated features, whether they have oscillopsia or not. And it's very important to go through the history and examination. And pendular nystagmus, if we look at the differential diagnosis of pendular nystagmus, congenital or infantile nystagmus is not the only cause. If it is acquired pendular, it's very important to differentiate it from acquired pendular, because which can happen in multiple sclerosis. In multiple sclerosis, you can see a pendular variety of nystagmus, and there could be sometimes patients with oculopalatal myoclonus, spasmus nutans, visual deprivation nystagmus. So it is one of the differential diagnoses, but there are other causes of pendular nystagmus which can be developmental also, which can be acquired also. Then coming to the reversal on optokinetic testing. For example, in this patient, I offered the patient the left to right stimulus on the optokinetic stimulation. In this, normally what happens is the patient should get left beating nystagmus. When the strips are moving from left to right, the patient usually gets the left beating because they slowly pursue it towards the right, and then it beats towards the left. So they get usually left beating nystagmus. But in this particular patient, you see this patient had, instead of left beating, the patient had right beating nystagmus. Okay. Now, and one more interesting finding I saw, it's not that always you will get reversal of nystagmus. it might happen that it reduces the gain of the nystagmus. That also can happen. I'll show you. First, I'll show you again now in this patient. One second. Yeah. When I offered the right to left stimulus, normally the patient should have right beating nystagmus, but the same patient had left beating nystagmus. You see here. Mm, yeah. So the patient is having left beating nystagmus. I hope you are able to appreciate. It all depends on my uploading speed, downloading speed, and your uploading speed. So yeah. So this is about the reversal, and it's not mandatory. Like because of this VNG system, what is happening is we can appreciate a lot of things. This is about the first patient. This is normally what happens in other patients. For example, this is another patient where optokinetic left to right when the stimulus we give, the patient gets left beating nystagmus. Here you can appreciate that left beating nystagmus. But in this first patient of mine, the patient had left beating nystagmus, but the you see the gain was very less as compared to the usually what we see in normal. The gain was very less. It's not that reversal should happen. Sometimes it can happen that the gain is less. For example, the same patient right to left, this is normal patient like another vestibular disorder. The patient has right beating variety of nystagmus. You can see the right beating variety of nystagmus, and this patient had right beating, but the gain was less. The gain was very less as compared to the normal optokinetic nystagmus. So it's not that always it should be reverse. It can be there can be reduction in the gain. So that's what I have found. Only in two patients I have. One patient there was reversal, and one patient had reduction in the gain. Now coming to the next finding, that is T. T stands for tilt of head. The head tilt I have already discussed. The patients can develop head tilt because of the null point. Because of the null point, they try to adjust their vision so that they are looking at in the null point, through the null point, and they're trying to keep the straight ahead position by head tilt. And they actually they feel the way vision improves, the foveal vision improves in this position, and that can be used as a tool for surgery. That if the patient has head tilt, the surgery can help them. um, then the A stands for abolished in sleep, lead closure, and accentuates on attention and anxiety. So let's see this point. So in sleep, typically it like abolishes or reduces on lead closure or lack of attention. But contrary to this particular finding, what I have seen, there is no mention about visual fixation here. But I have seen that I have two patients. In one patient, there was a reduction. There was a change from the pendular variety to the jerk variety after removing the fixation. And in one patient, conversely, there was increase in the velocity, increase in the amplitude and velocity of the nystagmus. That's what I have found. That's what I'm going to show in my graphs. And it accentuates on fixation. That's what is mentioned in the literature. Fixation enhances the nystagmus, but I will show you in one of my case on removing the fixation, the patient had increase in the amplitude of the nystagmus on and other things which can accentuate the nystagmus are attention and anxiety. Now, coming to this case one, for example, in this patient, if you see, this is the pendular variety of nystagmus. Okay, I'm not drawing it properly. This is pendular variety of nystagmus, and if you see here, it has become a jerky in nature. On removing the fixation, the patient had conversion from pendular to the jerk variety. That was seen. That is something which I was very much surprised to see. and I don't have like explanation for that. And another thing is, in second patient, what happened is the spontaneous in light. For example, there was no nystagmus or very subtle nystagmus. You can see it here. You can see this subtle nystagmus. Typical the velocity. If you see the waveform, if you can see the waveform, you can appreciate that initially the velocity is less, and later on in the later half it increases the velocity. So there is exponentially increasing slow phase velocity. And in dark, if you see, there was increase in the slow phase velocity as compared to the light. So with fixation, actually there was reduction in the intensity and amplitude and velocity of nystagmus. And without fixation, the patient had a typical nystagmus which is seen, and the patient had uh, typical this exponentially reducing velocity waveform. You can appreciate here the waveform is like this. So the initial part is of very slow in velocity, and the later part is faster. So that is what it is seen here. Now the last component is a latent component. The latent component appears only under certain conditions of visual fixation. There is an increase in nystagmus amplitude occurring when one eye is covered. When we cover one eye, then these patients usually, I will connect the battery 1 second. Okay. So there is increase in the nystagmus amplitude occurring when one eye is covered. When one eye is covered, the nystagmus becomes manifest. It is a latent initially, but when we cover one eye, the nystagmus becomes apparent. That is another variety of infantile nystagmus syndrome or a congenital nystagmus. And now I'm going to present another third case, like two cases I have shown during my presentation. The third case is a very interesting case of by Dr. Abhishek Gaurav. He's a neurotologist from Begusarai, Bihar. I'm really thankful to him for sharing his case. In this particular case, what happened is, she's a 6-year-old girl with progressive loss of hearing from past 2 months, and I'll play her video. If you can see, there are various findings. There is a squint. If you can look at the squint. And despite of giving repeated verbal commands, she was not following. So she had bilaterally hearing loss, and she had jerky component of the nystagmus on bilateral gazes, right beating on right gaze, left beating on the left gaze. If you look at her sparse hairs, alopecia, loss of hairs, the hairs are looking brittle. And let me play the video again for better appreciating the nystagmus. In the center gaze, there is a pendular variety, and you can see the neck was held by the physician. So maybe she was having the tilt also, and even the titubation, like the head oscillations also some patients can have if they develop this early. And on right, there was right beating, left beating on the left gaze. So she had gaze evoked nystagmus. And another important finding she had was the dystonia. She had dystonia of the hand. Okay, so each of these are clues for the diagnosis, and so these are various clues in her case. Direction changing gaze evoked nystagmus, head tilt to the right. Maybe she had head oscillations also, dystonia of the right hand, bilateral hearing loss, brittle and lusterless hairs, and there was strabismus, and with associated this congenital variety of nystagmus. So I tried to find out what could be the reason. If it is uh, developmental, like neurodegenerative disease syndrome, then I could find out a disease where the patient also had intellectual disability, hearing impairment was there, and there was visual impairment. I'm not sure visual impairment was there, but in maybe most probably she had this particular syndrome. If the other acquired pathologies are ruled out, I'm not sure about the diagnosis. This is just food for thought, and I could find out the correlation between infantile variety of nystagmus and dystonia. So this was about the like infantile nystagmus syndrome. Now I will go to the summary of my findings, clinical findings of motorist vestibular disorientation syndrome. So those of who didn't attend last time, motorist vestibular disorientation syndrome is a disorder where the drivers, specifically drivers, feel while driving the vehicle, they feel disorientation, dizziness, palpitations, variety of symptoms, especially at higher speed, bends and turns, multi lanes, slopes, while overtaking a big vehicle, and looking at other vehicles while at signals or in motion. So here in Dubai, we have complexity of roads. So looking down from the bridges, then the turns. Some of the drivers, like what in the my case series, around 15 patients, they had problems in the turns, looking down from the bridges and slopes. Whenever they are going on the slopes, they had issues like downward slope. Some patients had issues, upward slope. Some patients had issues, and multi-lane highways. Multi-lane patients feel a lot of problems in multi-lane highways. If their lanes are more, then the patients can experience disorientation. And this video I have shown last time, where the patients can experience this dizziness or disorientation or palpitations. It creates a lot of anxiety when the optic flow on right or left is asymmetric. The visual information coming from the left side and right side, if it is not matching, the patients can develop a lot of disorientation, and they can develop dizziness. So this is one this thing. And multi-lane, they develop problems, and whenever there is large vehicle which passes from one side, then also these patients develop disorientation. That is single lane, there is no issue. Usually the single lanes is not a problem. In single lanes they can go comfortably, and in bends they have issues, like particular bends, right sided bends, they can have issues, or left sided. If they have one sided issues, they will have only one sided like bend issues. Like for example, I have some patients who told me they have issues on turning to the right. Some patient told they have issues on turning to the left. I am going to show you that analysis. And the next is overtaking. I have shown overtaking, and looking at other vehicles while driving also can create feeling of dizziness. So this is about this thing. So now coming to the summary of my findings, I have in my in our registry we have 32. The age group is 32 to 64 years. Most of them were in fifth decade, and majority were males, like 16 males and 2 females. 8 out of 18 patients were driver by profession, they were drivers, and 13 out of 18 had more than 10 years experience of driving. So it's more common in people who have minimum driving experience was 5 years. So in people who have drivers from long, it develops. It's not something which is related to the early phase of learning the driving. Many a time we feel a lot of anxiety, panic. That is different, but this is something which happens in people who were drivers for long duration, a minimum 5 years. And the triggers, as I mentioned, were this: 10 out of 18 patients had history of migraine, which needs to be evaluated whether the migraine or vestibular migraine component is triggering this particular functional disorder. and 9 out of 18 patients had some symptom of motion sickness during the travel. And duration of illness was it ranged from 8 days to 10 years. So what happens in triple PD also, the average time required for the diagnosis is 4.5 years. And motorist vestibular duration disorientation syndrome is also a type of functional disorder, and we need to create a lot of awareness about this disorder, and early recognition of this disorder is important. So this 8 days is a patient whom I have seen recently. What happens is, with time, during last 3 years, I have gathered these many cases. So with time, what happens, the time to recognize this disorder, time to diagnose this condition considerably reduces, because these patients keep consulting different doctors, ophthalmologists also, because they feel a blurring of vision, and they can have visual vertigo, and that's what it happens. And the episodes can range from few episodes to a daily suffering. Some of my patients, they have daily episodes, and some of the patients, they are very lucky, they feel it only few times and then it goes away. So it is a spectrum, it is not a constant natural history where everybody suffers from it. Some patients have mild variety and some patients have a chronic variety. And which symptoms, this was the question posed to the participants. So most of the patients said that they experience like a kind of unsteadiness or imbalance, and dizziness or vertigo, and also disorientation was a very common feeling. Most of the, and palpitation, because this what happens is, it causes severe anxiety because they are in high speed, and then they develop this disorientation, this kind of feeling. So that's why they become very much anxious, and it can actually lead to sweating, and it can lead to uh, like misdiagnosis of cardiac condition, cardiogenic syncope. It can lead to that. Of course, that needs to be ruled out, uh, but that can happen. In most of the patients underwent, even some of the patients underwent cardiac evaluation. So changes done in the routine by some patients were slower speed, avoiding fast lanes. Some of the patients stopped driving, and one of my patient, he took driving classes again. There is a provision here in UAE to, the drivers can take classes again to fine tune their driving. And how long the symptoms last once they begin during the driving, most of the patient answered it continues till they drive, but it can be short lasting. And as once these symptoms start, they have to pull over the car or whatever vehicle, and they have to take rest, otherwise it becomes very difficult to continue the driving. And one of the question was, what were the triggers. So most of the participant answered the higher trigger, higher speed was a trigger, multi lanes was a trigger, looking at other vehicles while driving, bends and turns were a common trigger, overtaking was an issue, looking down from the bridges, downward slope, four patients had issue, and upward slope, four patients had issue, closed tunnels was a problem for three. And but of course, many of them had more than one of these triggers. So, and six participants felt it is like right sided, the vehicle was veering to the right side, six felt that it is veering to the left, and four participants didn't feel any veering of the vehicle, in any turning of the vehicle on one side. Giddiness, which time of the day they felt the symptoms were more, and why I showed this particular is the patients who experience this more in the evening time are the patients whom we should look for the associated triple PD, the presence of functional disorder, that is persistent postural perceptual dizziness, is common. We have to see whether they are developing or they are already having this particular disorder, functional disorder. And any of the symptoms apart from above, again, this symptom is very important: fear, or dizziness in open places was seen in 4 patients. So these are the patients who have associated agoraphobia, which could be a marker of functional dizziness. And these are the symptoms which are markers of vestibular migraine. They could be having associated migraine or vestibular migraine, because that could be a trigger. So this is something akin to functional dizziness, that is triple PD, where in triple PD what happens is 70% of the times we patients can have underlying vestibular disorder which precipitates it. 30% of the times we don't find any disorder. Similarly, in motorist vestibular disorientation syndrome, patients can have underlying vestibular disorder in the form of vestibular migraine, or patients can have even vestibular paroxysmia. Two of my patients had vestibular paroxysmia. So, any of the following symptoms of motion sickness? Yes, the patients also had motion sickness. Symptoms of motion sickness in the form of nausea, vomiting, giddiness, imbalance, yawning. Yawning is an important feature of like after travel. If you are experiencing yawning, it is a mild form of motion sickness. Patients can experience headache, irritability, drowsiness. Drowsiness also can happen in patients with motion sickness. So motion sickness happens as a traveler, and motorist vestibular disorientation syndrome happens as a driver, like the disorientation or dizziness which happens as a driver. But patients with motorist vestibular disorientation may have associated even motion sickness also. So in this study we could see that some of them were having associated motion sickness. Now 10 patients, I told that they had associated migraine. So it was either in the form of heaviness in the head or throbbing headaches, or it was dull aching pain, or they couldn't explain, or it could be throbbing or pulsating variety of pain. And the triggers, they were typically like migraine triggers. The most common was lack of sleep. And how did it affect the activities? This symptom is very important. Difficulty in focusing and concentrating is a very important symptom of vestibular migraine or visual vertigo. So it's very important that we should try to find out any clue in this patient to treat them as vestibular migraine, and then their underlying this disorder will also improve. That's what I have done in these patients. I treat them like migraine, because most of them had associated migraine, and many of them had improvement in their symptoms. So the drugs which I used are, if you look at these drugs, they are all first 5 drugs are all used in migraine. So we have to treat them like a patient with vestibular migraine, or a patient with triple PD, as for example, like functional dizziness. We treat them with SSRIs, SNRIs, tricyclic antidepressant. Beta blockers also help in my experience. Magnesium also helps in these patients. And of course, if they are not responding, then we can try other medications where gabapentin and pregabalin has associated anxiolytic action, and that's how it helps in this disorder. Plus, they can be having associated vestibular paroxysmia, vascular loop, and that's how it helps. The gabapentin, carbamazepine, and pregabalin can help. So I don't have data to back up my these findings, but I'm going to publish this case series soon, and let us see like how the experience at other centers. I will interact with other like colleagues, experts in this field, but I am finding that the patients improve with this therapy. And that graph I'm yet to analyze, like how much percentage improvement they had with which drugs. And some of the patient I used even the combination of drugs. So in pure form it was seen in 12, and associated migraine was seen in 10, vestibular paroxysmia in 2. One patient had old episode of vestibular neuritis in his VNG, and one patient I have shown last time, he has early Parkinson's, where one body he has rigidity and he feels that the car is veering to the one side. And one patient had associated myoclonus, in which in this particular patient, the antiepileptic drugs help the patient to recover. So the natural history ranges from complete improvement to more than 50% improvement, and those who don't undergo any form of treatment, like we should try to investigate what is the underlying reason and try to treat that particular disorder, and that can lead to a lot of suffering. So it's very important that we should offer some form of treatment. And I'm really thankful to all of you for sparing your time, and I'm thankful to again Sahasra Inti Foundation and Sriharsha for giving me this opportunity. And now we have completed 12 talks, and over to Dr. Sriharsha. You can moderate the question answer session.
Thank you, sir. As you rightly pointed out, this is one of the longest webinar sessions, and we are really happy that you are putting a lot of effort in making these presentations. I'm sure all the audience will agree with me on this. So we'll take questions from the audience. Anybody who wishes, you can unmute and interact with the speaker. Before audience, I would like to ask one question. Sir, you were in the initial part, you were saying people with children with albinism have some kind of nystagmus. What percentage of albinism kids have nystagmus?
Dr. Sriharsha, I didn't get your question. Can you repeat again?
What percentage of kids with albinism do you see nystagmus? My question was basically, do you screen for nystagmus in all albinism patients?
Yeah, see, whenever patients present with for some other neurological symptom, and they have it is a part of routinely I check for eye movements in most of the patients. And usually in patients with infantile variety of nystagmus, they have obvious nystagmus. Even when you are taking the history, you can see that nystagmus. Honestly, but I haven't seen a patient with albinism with nystagmus. I haven't seen, because usually these patients will go to even during the childhood, early life only, they will show to the pediatrician or pediatric neurologist. Usually what I see is in last 3 years I have seen these two cases where adulthood they had this congenital. Another case was there, but unfortunately she lost to follow up. I couldn't record her VNG. Three cases I have seen, out of which two didn't have any neurological or ophthalmological abnormality like visual problem, and one patient had strabismus with visual with squint, with this null zone, and she had difficulty in focusing, concentrating, and she was using the head tilt for the this vision. So you can see a spectrum of these patients with this infantile nystagmus syndrome. It's not that if you must get this pendular variety in all patients. You can see a lot of variations in individual patient, as I have shown in my presentation. Only two patients I have, but both these patients, one patient had reversal in optokinetic, one patient didn't have reversal. There was reduction in gain. So it's all about spectrum. Like it can be a mild to spectrum ranging with whole features of all albinism, or other neurodevelopmental features can be there.
Yes. So the key for diagnosis is prior knowledge on this subject, I guess, because most of them usually don't present to us in their initial sessions. Maybe we refer from pediatricians is the key.
Yeah,
With questions from the audience, anybody can unmute and your question. We had one comment in the chat section by Dr. Mohammed Hamid. Well, you were discussing about motor vehicle eye migraine. Those subjects are mostly male. About migraine.
Why migraine?
Dr. Mohammed Hamid, can you unmute?
I'm here, Vishal. My question really is, the majority of your subjects were male, and I'm surprised that you have high incidence of migraine. And, it's obviously a small number, but I was not expecting to see migraine in a male population as such.
Mhm. So, Professor, thank you for your question. And so, here in my neurology clinic, I do see patients with like headache. I run a headache clinic also, and you will be surprised to know that like in my registry of headaches, like the 50 around, just little percentage is higher in females. Around, if you see, around 52 to 55% are females, and rest are all are males. And it's not that it exclusively happens in females. It can happen in males. And even I have migraine. And in the audience also, if we take a poll, many of us especially we did this poll in neurology group, our neurology group, and most of the neurologists we male neurologists, we were having migraine. So it's not that exclusively migraine is a phenomenon which happens in females. It just little percentage is higher in case of female, but that uh, does and this particular thing, like motorist vestibular disorientation syndrome, specifically it is happening in drivers which are usually males. And the higher percentage of migraine again goes in favor that it has some implication in the pathophysiology of this condition. And but by and large, the migraine in a male, it doesn't like, it is not something which is unusual. I commonly see patients with terrible migraines in even in males.
I mean, I'm sure you know that epidemiologically, migraine is about 3 to 4 times in the female population. But perhaps because of the uh, riders, motorcyclists in the world, you take it as a population. The majority are men, of course. So that might be a reason why. But it's very interesting. And I think most of these people will probably have some autolytic dysfunction yet to be determined, because I ride, and I wouldn't call myself experienced driver, but been riding for quite a while. You actually have constant autolytic stimulation during motorcycle riding, and those with motion sickness in regular cars would be more prone to have these symptoms if they're also riding a motorcycle. But yes, we would like to see this published, hopefully soon. Okay?
Yeah, thank you, Professor. Thank you for your comments.
Yeah, yeah. Pleasure. That was very good.
Thank you, sir. Thank you.
Any more questions from the audience? I will take. I think that's all, sir, for the day. Thank you, Dr. Vishal Pawar, sir. Excellent collection of cases on motor disorientation syndrome, and the continuation part was really wonderful, sir. Your collection of cases, I'm sure we'll be publishing interesting papers on this topic. And also infantile congenital nystagmus. This is one rarely spoken area in the field of vertigo. Uh, sure, all the audience who have attended today had a very uh, good collection of cases and take-home messages. And, of course, if we find any new interesting cases, we'll also be sharing with the audience for the benefit of all the doctors. Thank you, sir. You have been a very consistent speaker with us, and I'm sure we'll be having one more year of interesting talks. And, thank you once again. We will be seeing you again on October 1st, Friday, 7:30 Indian time and 6 p.m. Dubai time. Thank you all. Good night.
Thank you. Thank you.